Good evening, all my friends over here in India, and good morning, a very, very good morning to all those who are in the United States of America. And this is a very momentous occasion for all of us. We are having a historic 100th episode of this continuing medical education programs, the CMEs on COVID-19. This was started way back on 9th of August 2020 when the initial spark was ignited by Sri Vinay Chand, IAS, the then District Collector of Visakhapatnam, who has told me that we have to have some knowledge exchange between the experts so that we can follow the protocols better in order to have the better outcomes. With that in idea, we thought we would conduct about 10 or 12 such sessions, but it went on to 100. I'm very glad about that. And this being the 100th episode, I felt it is very appropriate that the highest in our state who has been handling the health issues, Sri Muddad Ravichandra IAS, the Principal Secretary of Health, be present here so that we will all have a sort of inspiration. And he is the one who is handling the situation in the entire state of Andhra Pradesh so well. And before I ask Dr. Muddad Ravichandra, IAS, I wish to tell a few important aspects of how he is and what he has been doing. He is the Principal Secretary of the Health who takes important decisions, not only on the protocols but also on the entire system, healthcare delivery system in the state of Andhra Pradesh. He is not new to the health department. He is very well known for his meticulous planning and a very expeditious execution of all those plans. Being the MD, Managing Director of Andhra Pradesh State Infrastructure Development Corporation a couple of years ago, he was instrumental in bringing in a lot of reforms in the healthcare delivery system of Andhra Pradesh. He, in fact, changed the healthcare scenario so much that earlier we used to have only the APC and B complex tablets in most of the government hospital setup. But now, after he became the MD of the APMS IDC, he is the one who has introduced the system of procuring the medicines centrally and expanding the number of medicines that are available to the government institutions. He took the advice of the professional bodies, particularly the doctors, in ordering all these medicines. So during his tenure, the healthcare delivery has significantly improved throughout the state. And in between, he went to the other important departments, and he came back to the health department to our fortune. And he is the one who has been responsible for increasing the number of, along with the state government, in the state government, the number of posts that are being filled now. You must have seen that thousands of posts of the doctors as well as the nurses and paramedical staff are being filled in the state of Andhra Pradesh. And he is the one who is responsible for that, and he does it is in such a speed that it's very difficult for all the officers behind him to follow him. So he is the person whom I thought would be most appropriate, and for convincing him to come to this session, Dr. Raviraj Garu has played a very big role, and I am really thankful to him because Dr. Raviraj Garu has been our teacher and a motivator. And before Dr. Raviraju speaks, I would request our chief guest today to make certain opening remarks, Sri Muddad Ravichandra IAS.
Thank you, sir, for that many good words spoken, some which are could be true and many I'm not very sure. Thank you for all those crediting, for all the teamwork to us, whatever it is. And first, let me congratulate the entire team led by AMC, Andhra Medical College, which is a very prestigious institute, and its alumni, that's AMCANA, and all the leading doctors who have participated in the 99 odd episodes that have taken place. And 100th episode is definitely a milestone which the entire team is proud of, and the contribution made is immense. Thank you once again, Principal Garu and the entire team, all those team who made it possible, all the contributors, everybody. Now, in brief, I wouldn't like to stand in between the useful part and the whatever ceremonial part. Basically, in Andhra Pradesh, today I think we are reasonably well prepared. We have a good testing capacity. On the RT-PCR itself, we can test about 80 to 90,000 per day. I'm not talking about the rapid antigen, only talking about the RT-PCR. And genome sequencing also we will be starting in a very few days. Most of the material is ready in Vijayawada. It would start, probably we're targeting to start by 15th. If not 15th, it could be a little within a week's time it could start. And coming to tests, I think we crossed about 3 crore tests in this from the day we started testing. We have a population of about 5 crore. Of course, many were tested more than once, but still 3 crore is a decent milestone. We have vaccinated roughly about, at least with a single dose, about 93 to 94% of our eligible population. We are now trying to go door to door and see if somebody has missed out. And a good 65% have been vaccinated with 2 doses, which is probably one of the highest in the country. The country as a whole stands at somewhere around 45%. We stand at around 63, 64%. So on vaccination front, some care has taken place. We are capable of testing. Then on the treatment side also, the preparedness has been reasonably good. I think we are prepared with to face the third wave with about I see about 24,000 oxygen concentrators in place, about 28,000 cylinders in place. Apart from so many PSA plants which are going to get inaugurated tomorrow, that's what Vinay is preparing for, because the Honorable CM would be dedicating to the state or nation tomorrow all the PSA plants. This thing, their running would be a challenge definitely. Which I hope we will overcome this thing. And the number of beds and the number of doctors and the paramedical staff are in good numbers, and they have really worked very, very hard in the last 2 years. Everybody did their bit. They had multiple roles, so everybody did their bit with a lot of sense of sacrifice. We have lost a few people, but nevertheless, I hope the society remembers that the sacrifices made by many of the people from the medical fraternity. And we are trying to do our best to do something to their families and who have sacrificed in the larger interest of the public. And with these few opening remarks, I once again thank all the continuous people who have participated in this continuous education program and shared a lot of thoughts, gave a lot of guidance. And when there are so many different opinions, when the world's highest body is not able to come to a fixed opinion, of course, diversity is always very, very good. And we have been getting different opinions and different theories, some being shown very good today, some being debunked tomorrow. But nevertheless, as a whole, we have been evolving. And today, I think the knowledge the common man has about the knowledge and the awareness the common man has about this particular disease or pandemic or whatever it is very high. Today, incidentally, I think we have our first case of Omicron in Vijayanagaram area, but of course, with not much of any symptoms or not needing any hospitalization. So I hear another version that it's again turned negative. One test has turned negative. So let's see how it moves. Nothing to panic or anything. I think this state, apart from the country as a whole, is ready to face any eventuality, thanks to the medical fraternity who have shown a lot of courage and willpower at the time of need. Thank you very much, and I look forward to being enriched by this gathering. Thank you.
So, thank you very much, sir, for your updated information to all those who are around the globe. And your words have been very encouraging. And I'm sure, even if we have a third wave, we are ready to handle that very effectively under your leadership. And before I speak for about 2 or 3 minutes, I wish to inform Dr. Raviraju Tatpudi is here, and he's the one who gave the first lecture in this session. So emotionally we are very well connected, and he is a role model for all of us, being a teacher of extraordinary caliber. And I would request Dr. Raviraj Garu to share his thoughts on this program over the past 1.5 years.
Good evening to all those in India and good morning to all those from US. Thank you very much, Dr. Sudhakar, for giving me this opportunity today evening to address all of you and give some of my reminiscences about what has happened during the last 1.5 years and something about the webinars we have been conducting very successfully. I'm extremely happy that we are celebrating this academic feast of hundreds webinars continuously in a row without any break, which is really a historic event, I suppose. I don't think that it's possible normally to have 100 webinars going on without a break on the same topic. I'm equally happy that Ravichandra Garu has come today to address all of us and motivate us. As we have already said, he is nothing new to the Department of Health. He has been associated with the health department, the problems of health department, and also the problems of doctors for a long time. And that's the reason why, under his great leadership, Andhra Pradesh has gone very forward, a way forward in the testing and also containment of COVID in our state during the last 2 years or so. It's needless to say that we have done the largest number of tests in the country. And as he has already pointed out, it is also the place where we have done, where we could contain and also do the vaccination to majority of the population of eligible people of Andhra Pradesh. Not only the first dose and second dose is also going on. So it is all his vision and dynamism that made us almost COVID free today. And thank you very much, Ravichandra Garu, for accepting our invitation and coming to this meeting in spite of your busy schedule. I know how busy you are even on Sundays. And you told me that you will be going after some time, but I request you, if possible, to stay through and listen to the excellent talk that will be delivered by Dr. Sridhar, and also the remarks that will be given by Dr. Ram Kairam. It will be very interesting to see. So I'll give you after the first meeting was done on August 9th, once the COVID has come to India, the pandemic was announced in India in March 2020. We had several lockdowns, we had curfews, things were going on. We had lots of difficulties. Not only the health problems, the economic and social problems, the destruction of the social structure has occurred because of COVID. And all of them we wanted to overcome. That is one. The government has done an extremely good job in Andhra Pradesh in dealing with COVID. They have also conducted a lot of seminars. I was also part of the COVID expert committee. We were sitting together and giving guidelines to all the doctors and all the hospitals, how to go about with COVID, how to treat these people, how to diagnose COVID and their complications. But at the same time, Dr. Sudhakar has conceived and conceptualized this new idea of having a webinars for all of us, so that the knowledge of the students, knowledge of the practitioners, and knowledge of all those who are dealing with COVID will be updated. And we will know the guidelines, we will know the ideas of the government, and at the same time, we will be executing properly and mostly very ethically without resorting to unnecessary practices and also using unnecessary medication. With that, he has started this very webinar. But what has happened subsequently is something, it's a serendipity. I feel it has happened because the MCANA doctors have joined this and they have almost taken over the responsibility of conducting all the webinars and successfully doing that. It's not an easy task, and this has augured very well for Andhra Medical College and the principal, and we could conduct these webinars in a very effective manner. And it is all the leadership of Dr. Sridhar, who is I would say, I would not hesitate to say, an epitome of knowledge. Epitome of knowledge, not only general medicine, but also the COVID. And he has enormous experience. By that time, he had enormous experience in the management of COVID patients because he works in New York in Bronx Care Hospital, a very busy locality. And by that time, New York was the epicenter of COVID. So with all his experience behind him, he started giving these lectures, and his original work, his scholarly reviews, and also his masterly expeditions of about the COVID has gained the imagination of all the doctors. All the doctors in Visakhapatnam district and also all over Andhra Pradesh. And it's not an exaggeration if I say that people were simply waiting to listen to him, and they were waiting for the Sunday morning. All these meetings were happening every Sunday morning, and by 6:30 they were glued to the systems to listen to him. And to add flavor to this, we have our moderator, Dr. Ram Kairam, with his pristine English and meticulous way he was handling the whole thing. He was giving very good remarks, poignant sometimes and very punching remarks at times. And he was adding a little humor in between also. With that, the webinars have become very popular. And he was the one who was organizing the whole thing, getting the speakers from various parts of United States of America. They may be old students of Andhra Medical College, or they may be experts from some other colleges, but still they obliged him, and they used to come at 9:30 p.m. in the night or a little later and give lectures to us, so that for the benefit of students and the practitioners of Andhra Pradesh. So this is the distinguished, we have a set of distinguished speakers and also one distinguished moderator. So with that, all the seminars have gone on very well. Not only the speeches and the moderation was good, the main important thing was discussion. Discussion was the best part of that. The speakers encouraged all the listeners to do the discussion very freely, with the result that the treatment modalities, the various aspects, the updating of COVID problems that has come to their minds, and we were very lucky that way that we were all updating ourselves without much effort. And I'm also lucky that one of the speeches was done by my son, who is a student of Dr. Sridhar in the US. And that's how all these talks were going on. To name a few, Dr. Guntupalli Kalpalata was the one who from Baylor. A wide variety of topics were discussed, not only something related to COVID and pulmonology. Every system in medicine, every system in human body gets affected because of COVID. So experts from various fields of medicine were called in, and they were asked to give the lectures. And one of the interesting topics was given by a couple of times by psychiatrist Dr. Bush also. So like that, several experts from the Bronx Care Hospital have come, they have delivered their lectures. With the result that we had a series of webinars over a period of nearly 1.5 years going on continuously without break. And all of us were immensely benefited by that. And I am extremely grateful to Dr. Kairam and Dr. Sridhar. We have made this possible, and also for the perseverance of Dr. Sudhakar, who made the whole thing a reality. As far as the kidney goes, just I would like to say a few words. We have several problems with the kidney disease in the last 1 year because patients were not getting enough of supplies for hemodialysis. Patients were not able to come to the hospital because of lack of transport because everything was locked down or under curfew. But the government has come to our rescue. They were providing transport. They were providing all the facilities to be transported to the hospital without break. All the supplies were given. I profusely thank Mr. Ravichandra for all these efforts he has made to see that kidney patients did not have suffering. A lot of patients who had transplantation and subsequently suffered from COVID succumbed to that during the first wave of COVID. But during the second wave, we could handle them very effectively. And I remember that one of the very senior IAS officers' niece who had a transplant developed COVID and she succumbed to that subsequently. But we could save several people. And we had the satisfaction of publishing it 2 or 3 papers in International Journal of Nephrology about how COVID patients, how kidney transplant recipients with COVID were behaving and how we were managing. We had our own experience from India. So like that, also from the Indian Society of Nephrology, we have brought out guidelines not only for the management of kidney transplant recipients with COVID, but also how to run the dialysis units, both hemodialysis as well as peritoneal dialysis. So with these few remarks, I will hand it over to Dr. Sudhakar for continuation of the program. And I once again thank Dr. Chilamuri and also Dr. Kairam for the great efforts they have made during last 1.5 years to educate everybody concerned. Nowadays, everyone is a COVID expert, but still updating and doing it in a very ethical way is very important. And also, I thank Mr. Ravichandra for coming here for today's meeting and also encouraging every one of us and also taking good care of the Department of Health and also the people of Andhra Pradesh as far as their health needs are concerned. Thank you very much for giving me this opportunity.
Sir, thank you very much, sir, for your scholarly words, and hearty congratulations from all those who are there in this forum for getting this Lifetime Achievement Award from the Indian Society of world in this country as well as in this state. So thank you very much, sir.
Thank you very much, Dr. Raghava. Thank you.
Before I ask Dr. Kairam to introduce Sridhar, I wish to make few remarks. After the idea was parked in by Sri Vinay Chand, we have thought a great deal. Like Dr. Sridhar always says, that it is the intellectual exchange that is very, very important. And the AMCANA has helped Andhra Medical College in various fronts in improving the infrastructure, in providing a lot of equipment to this institution. And he always felt more than that, it is the knowledge sharing which is very, very important. And so we got this idea of having this particular program, which should be a worldwide one, and particularly with the cooperation of the AMCANA. And AMCANA not only had good speakers from themselves, but also they identified people who have actually worked in COVID-19. So, and they presented them to us so that we had a lot of knowledge. There are a lot of speakers from India as well. And to name a few, we have Dr. M.S.S. Mukherjee from Hyderabad, we have Dr. Arun Prem Kumar here, and so on and so forth. In America, Dr. Sridhar is the one who has led the hottest spot in the world, the New York City, where we had thousands of cases he has handled. And more importantly, not only seeing the patients upfront, he also has contributed enormously for the knowledge by way of publications. He is a prolific writer, and he has almost 20 publications in 1 year on COVID-19 itself, indicating that his knowledge is so enormous and he has contributed significantly for the development of science. And Dr. Ram Kairam has always been my source of strength, because he is the one who used to organize the speakers from United States, and particularly we had exemplary speakers like Dr. Muhammad Adrish, Dr. Pratit Kulkarni, Dr. Kalpalata Guntupalli, Dr. Murali Krishna, Dr. Bush Kauru, so on and so forth. And we had scores of these speakers who made this particular program very enjoyable. I'll just give you an anecdote here. A couple of days back, I met a doctor from the rural area of Srikakulam in a function, and he said that when this particular program has started, before this particular program was started, they always used to have only one thing in mind when they were encountering a COVID-19 patient, whether to refer that patient to Vizag or to Srikakulam, the headquarters. But after listening to these webinars, after being a part of these webinars, they not only became very confident handling these patients, but also they have saved many a life. So basically, listening to that, I felt that our mission is fulfilled. So this is the reason why we exactly wanted this particular webinars to be conducted over and over again. So it has helped all the practitioners in the rural area. It has brushed up the knowledge of those who are in the teaching and who are regularly following the protocols. And it has helped all those who have to keep abreast with the changing protocols. As you know, when we started in the beginning, we thought that the plasma is the game changer, but it did not happen. It has become obsolete over a period of time. So this basically shows us how science changes over a period of time. And we had all that great knowledge from experts here, as well as when we interacted with those who are abroad, they always acknowledged that whatever they have been sharing with us, they also got equally benefited by our own thoughts and our own way of management as well. So over a period of time, after 20 or 25 episodes, we realized that we are getting this wealth of knowledge cannot go waste. It has to be permanently secured. So we have started a YouTube channel by name Andhra Medical College Kama Vishakhapatnam channel, and we have all these talks are available in this particular channel, and it is a big repository of the thoughts that we all had and the knowledge that we have shared amongst ourselves. So this our thought also was given by Dr. Ram Mohan Kairam. He said that why not we have this repository of the wealth of knowledge that is being shared by the experts from both the countries. So we had that thought, and now anybody can visit these and go through the areas of their interest. So we have started dealing with this from the children to the adults. From womb to tomb we have covered these topics. Similarly, from head to toe we have covered the topics. So that is the variety of topics that we have covered. In the beginning we used to concentrate on the diagnosis, testing and so on and so forth. Later the protocols, and we have reached a stage when we have discussed with the psychological aspects of the patient suffering from the COVID and the long COVID syndrome as well. What is the aftermath of this COVID-19? So that is the extent, that is the length and breadth of these topics that have been covered. Today you can see again we are into the future. So what is there in future that we have to encounter is the topic that's going to be covered by Dr. Sridhar Chilumuri. And Dr. Ram Kairam belongs to 1906. All of us, and he is basically like a guru for all those people who go from India to United States. He guides them. And there are many other alumni who have been helping us, Dr. Prasad Chalasani, Dr. Nagendra Maineni, and all these people have been contributing enormously, not only for our knowledge, but also towards the infrastructure of this college. And I am overwhelmed with the response that we have today. We have more than 400 people online, and we have about big screen. It's like a final of a World Cup. So it's something which is overwhelming for me. And most of all, I wish to thank our beloved Principal Secretary of Health, Sri Ravichandra Garu, because of his presence. This particular session today has its all in this college. He has been a source of inspiration for all the students. Whenever there is an important function or whenever there is an important event in this college, I always look forward for his presence, because speakers who have contributed in the last 1.5 years, as well as all those moderators program for being with us, and I look forward to carrying on this for, and we will have more of such sessions, and we will be informing you well in advance. With these few words, I'll rest my case and request Dr. Ram Mohan Kairam to proceed with the scientific deliberations today.
Yeah, unmute your microphone. So.
Dr. Sudhakar, you may not have become aware that your audio has been cutting in and out. I hope it will be fixed shortly. Good morning from me to all of you. Sudhakar mentioned almost 5-6 months ago that he would like to take these series of lectures all the way to 100. I used to constantly joke around with him. All of you guys are getting a little too carried away with cricket, hoping for a century. It is not that easy to get that many speakers at that time of the day on a Saturday night. But we succeeded in obtaining very qualified, experienced, knowledgeable speakers who were able to pay attention to evidence-based medicine. As the health secretary mentioned, even the world's highest body at the beginning of this disorder was not able to give consistent, reliable, usable information. So there was a lot of trouble in the beginning. Through all of that, this speaker for today, Dr. Sridhar Chilamuri, a graduate of Andhra Medical College, who has distinguished himself academically and in the delivery of healthcare services in New York City, has been my constant resource to be able to find speakers. And a large number of the speakers that we were able to get over the last almost 40, 50 sessions were his staff, his students, or postgraduates in his department, or people he connected me with. In addition, I was also able to fortunately connect with a lot of capable speakers. Therefore, we have reached lecture number 100. I notice we are already about 25 minutes into the session. As much as I have the responsibility for moderating it, I do not want to take away time from Dr. Chilamuri. When I first met him, he was a gastroenterologist and a program director. Oh my God, what have I seen in the last 20 years? This man is everything. So nothing could have been a more appropriate venue than a newly evolving disease called COVID-19 that was able to draw upon Dr. Chilamuri's wide knowledge of medicine, not just gastroenterology, but it is amazing how he has transformed himself into an all-rounder going back to cricket. So I won't take any more time. Dr. Sridhar Chilamuri, we go to him right away. Thank you.
Good evening, and thank you very much for having me, Mr. Ravichandra. It's a pleasure to meet you, and we appreciate all the support that you've given, both for our college as well as the people of Andhra Pradesh. Dr. Raviraju, it's very nice to see you again. I was your student a long time ago. And I particularly want to thank Dr. P.V. Sudhakar, principal, has been the guiding force through these 100 lectures. And more than that, guiding the people at the medical school to see that the best care is being given to the people of Andhra Pradesh. Yes, it's a 100th lecture, and it is a special honor for me to be part of it. But more importantly, I think we should see this as a milestone for the next phase. I think we are not in the home run yet. We are in sort of a cricket match where 100 runs is not enough, and maybe a triple century is needed, but we will get there. Today, over the course of the next several minutes, I will cover aspects of policy that we may have, strategy that we may have, a little bit of science, and then gleam into the future. One of the peculiar things about this particular pandemic is that whatever is about, either you see it in Europe or in the United States, and several months later, it starts showing up in India. So you should constantly observe what's happening in the United States, and we are more than happy to share it, because whatever is happening there or in Europe is eventually coming to India. And so you have time to prepare for it and develop strategies and policies for that. So going into the next phase, in the United States, as we speak today, Delta virus is again raging throughout many states. Because of the vaccine levels, we haven't achieved the vaccination rates that we wanted to achieve. And as a result of that, Delta has come back, even as Omicron has emerged in the US, which we will talk in a minute. But currently in the United States, we are seeing 120,000 infections a day, and we are back to having 1,200 deaths a day in the United States. So this is the future that you may see. So that's why I think preparing for it is a very good idea. So one of the first things that we are facing as we go into the next phase is the preservation of workforce. After nearly 2 years of working continuously with COVID, we find that there's enormous amount of fatigue in the healthcare system. Many nurses and doctors have quit in the United States. There are shortages all over the country. And what we have seen is that while we reflect on all the people that you in India have saved in the last several months with your amazing sacrifices and teamwork that you put together, and hopefully when you reflect on that, it gives you the resiliency to bounce back and continue on doing the good work that you were doing. So one of the things that we have to focus is on building resiliency in the workforce. So they will go on to do this for another year or two, because I think we are not done with this pandemic anytime soon. To do that, I think we need to develop monitoring protocols for entire healthcare force, whether it's nurses, doctors, technicians, to see how their mental well-being is going on. Can regularly conduct surveys so we have an idea of their mental well-being, fatigue, and sleep deprivation. Now, as we reflect back on everything that we have done, both in India and the United States, there are many things that we can be very proud of, and the number of lives that we have saved. But at the same time, this has not always been a story of success. There's been enormous loss. Thousands of children in India have become orphans. There are many who we have lost our colleagues, we've lost family members. So it has not only been a story of success, but it's always also been a story of sadness, loss, and anguish. And being a brand new disease that emerged in March of 2020, there are many things that we didn't know about the virus, but 2 years since, we have a much better understanding. We have better therapeutics available, and the opportunities to make new interventions are becoming available. But I think in the process of that, as we lost people, we can see what it has done to the lay public. Both in the United States as well as in India, there is because of the after effects of this pandemic, is an enormous distrust in the healthcare system. People demand things that are unrealistic. And And while we are still developing our protocols and understanding the disease and changing what we can do for them, we can only ask the lay public to be patient. We are not perfect. We're still developing as we go. And these frustrations being perpetuated or translated into harming or violence against healthcare workers, particularly in parts of India, is really sad. I think if we attack our own workforce, what we'll end up is we're gonna give the virus the victory even before we get into the fight. So I think the leaders here, one of the plea I have for them is that you should speak on behalf of healthcare workers in the public and say that the violence against healthcare workers cannot be tolerated. So moving forward, what has changed in our approach to the virus itself? So there's a clinical approach that we need to change. And why is it so? Because if you start in March 2020, when the virus first came into New York and about the same time it came to India, there was no immunity against it at all. So that was a different virus. So at that point, if you had a patient with pneumonia and PCR positive, there was a 99% chance that the patient had a COVID-19 disease. But that has completely changed now because India, as well as in the United States, people have had many infections. In fact, in the whole world, there are 250 million infections. 8 billion vaccines have been given all over the world. So now when a patient comes to you with a pneumonia and a PCR, you have to ask different questions of him. So now we would categorize people who you approach with a pneumonia and a PCR test as falling into one of these categories. If he's infected and vaccinated, so people who are previously infected and also vaccinated, and in that there will be two groups, those who have booster doses and those who haven't. And if you take that group, those who are infected, fully vaccinated, received a booster, and then you're seeing a pneumonia with a PCR positive test, you may want to think twice about that. Is that really COVID-19 or is some other actual different disease, maybe tuberculosis or pneumococcal pneumonia, and he just has asymptomatic COVID-19 at the asymptomatic SARS-CoV test? That's very likely because we haven't seen patients who are fully vaccinated with a previous history of infection and also received booster doses getting significant COVID-19 disease. Likewise, the least category would be the unvaccinated. And even today, if an unvaccinated person comes with pneumonia and the PCR test is positive, then most likely that person has a 99% chance of having COVID-19. So going forward, you want to categorize people into these vaccine status, those who are fully vaccinated and those who are unvaccinated and those who are in between, because I think that will guide you on how to evaluate patients going forward. So this should be now part of your history physical. When a patient comes in, ask them about their vaccine status and ask them about the previous infection, because that will guide you on how you will manage a patient going forward. The second thing is, because the spread of virus and its variants is so widespread, any new clinic, and the second thing is the protein manifestations of COVID-19. It doesn't spare any system in the body. Anything you take, the heart, the lung, the liver, the central nervous system, anything you think of, it can affect it. So when a patient comes with a clinical syndrome, because of the enormous amount of infection still prevalent, you need to ask these fundamental questions. Is whatever you're seeing now, is that a manifestation of COVID-19, or is it a manifestation of a non-COVID illness that has gotten worse from a previous COVID infection? Take, for instance, a patient who comes with heart failure. Is it just a heart failure unrelated with COVID, or is it a patient who developed myocarditis before 3 months earlier when he had COVID infection, and what you're seeing now is heart failure from the previous myocarditis, or is it just heart failure from hypertension? So again, each time you see this, this is a mindset in your clinical algorithm on how you're going to evaluate patients. And finally, although vaccine adverse events are very rare, they should be always be considered into your differential diagnosis. So anyone who presents to you with a new stroke or a new neurological syndrome or a new thromboembolic phenomenon, you should think about the usual causes of them, but always, since you've taken the vaccine history, you want to bear in mind that, yes, he received a vaccine 2 weeks ago, and now he presents with this new neurological condition. Is this a stroke? Is it a cerebral vein thrombosis? Or is it a Guillain-Barré syndrome? You want to think like that because we are giving vaccines all across the world, and we're giving millions of them. Although adverse events are very uncommon, it's still worth thinking that as the differential diagnosis. Now, going forward as a policy matter more than anything else, other than the vaccine status, what is the biggest predictor of death going forward with COVID? What causes death more than anything else?
I found this on the
More than anything else, what would actually cause death in patients these days? So you might think it is biological markers or age and risk factors, but it turns out from data that's collected in the US that the biggest risk factors that might increase mortality is not the status of the patient or the severity of the illness. It is actually the hospital's capacity. So in the United States, the 1 year of data where we collect every hospital in the United States on a daily basis, submits data about how many beds are occupied, how many of them have COVID, and how many of them are full of ICU, how many ICU beds are available. And what we found in the United States, once hospital reaches 75% occupancy of its ICU, deaths begins to rise. There's excessive amount of deaths once 75% to 80% of your ICUs are filled with COVID. Because we begin to drain resources, you begin to admit patients in compromised situations, or you may not even have the capacity to admit them into the appropriate beds. It's not uncommon for patients to be managed in wheelchairs and stretchers and not in proper units. So as a policy for healthcare, public health experts, what you want to watch is what is your bed strength and how is it being used on a constant basis? Because when these surges come in, they come in rapidly. And if you don't plan ahead enough and you don't monitor your bed occupancy status, you quickly the healthcare system can get overwhelmed, as it is happening in South Africa right now with the new emergent of a new strain. So we have to learn these lessons that when your occupancy keeps going up, that is the biggest predictor of death. So for any given condition right now, we can't ignore the fact that last year, there's a 30% excess death from all medical conditions that we have. So COVID directly caused deaths, but also modified the healthcare system so much because people are scared to go to hospitals. So there's delay of care for almost any condition that you can name of, leading to excess deaths. So we've been looking at all the other non-COVID causes of deaths in the hospitals like DKA, stroke, acute MI, and we are seeing a 30% increase in mortality. In 2020 was mostly because of COVID. 2021, it's not really COVID that's causing deaths. It is the after effects of deaths that COVID has caused because of the damages that it has done to both preventive care, ongoing care of many chronic medical problems. Earlier, Dr. Raviraju mentioned about the issue with dialysis and ESRD, what special efforts that the government of Andhra Pradesh took to make sure that people got that. So that sort of effort has to be done for many illnesses. And here's data coming from the United States, 80,000 admissions, where they compared people who had acute MI, who were hospitalized, and studied them to see the endpoints. What we're looking for is death or conversion to stroke or any other admission STEMIs, and then compared to see if they were COVID positive or COVID negative. And for every one of these outcomes, if you can see, if a patient is COVID positive, all the outcomes tend to be worse than people who did not have COVID. So even though COVID did not cause the STEMI, just the mere presence of having that test positive increases mortality one way or the other. It's perhaps because it actually affects the endothelium, or because it affects the healthcare system. If you're COVID positive, you're being managed one way. If you're COVID managed, you're managing different ways because there's a limited contact as we go forward. There are many therapeutics that we have talked in the last 1 year. I will comment only on a few so that I can, I'm just going to, so I can highlight the changes that are coming next. Since our immunity has changed in the last 1 year, is the clinically our patients presenting differently? And as I said, this change would first will show in the Western Hemisphere and then in India. So has the clinical presentation changed? So I'm going to show you data from 2020 in our own hospital to show that clinically, the disease has changed in how it's presenting to the hospital. So on your left panel, you could see these graphs, Kaplan-Meier plot, showing that we could easily categorize people last year in March of 2020. So into 4 categories: those who are young with no risk factors, they tend to do very well. On the other extreme, those who are old with multiple risk factors, they tend to be doing very poorly. And then 2 other categories which would fall in between. And this kind of predictive markers, which were written about, kind of worked out very well. But unfortunately, in 2020, those graphs have become smaller and smaller. In the wave that we are dealing with is quite a number of them are patients who had previous infection and got another bout of infection, or they had breakthrough infections from vaccines itself, or something different. This includes even unvaccinated. At least in our United States, most of these are Delta infections. We no longer see that separation of risk factors. In other words, there are enough young people with no risk factors who are also getting quite sick. And then on the other hand, there are people who are surviving also. So we are unable to predict with certainty who will die and who will survive in the coming forward because of the change in the viral characteristics or even the immune system. For instance, these are heat maps, and we will use the term first wave and second wave. I think it's better to understand this was March of 2020, and this is now. These are heat maps that show you how reliably, I mean, if it's very red, it means it's a really strong predictor, for instance, LDH and CRP. In that way, could clearly tell us the outcomes. And this wave, that's gone basically disappeared. So whatever markers we use so well, they become very attenuated. So it's going to be more difficult for us to triage patients and decide who goes to ICU or even who to admit. So this is going to be the next big challenge in the ongoing pandemic that we're going to face in the coming months. And just to illustrate a case, a patient who's 66-year-old generally will do poorly. A patient like this has a significant amount of pneumonia. He has a high flow of oxygen. He's PCR positive. So in a patient like this, in the first wave, we would have expected their LDH to be high, the D-dimers to be high, and CRP to be high. And yet you see there's nothing. The ferritin is hardly elevated. The CRP is hardly elevated. So this is what the pattern that we are seeing, that the biological markers that we were using before have become less dependent. And here's the CAT scan of the same patient. And so we're beginning to worry that what we used last year may not be so useful anymore. The second change that we are seeing, I think this is something we presented in our meetings before, and we are not so sure if this is, I think we are now more clear that when the Wuhan strain, most of the disease, this is a graph that I'm going to use quite often, that when you first get infected with COVID, the first 5 days, you are essentially asymptomatic. but you nevertheless shedding virus and you are infecting other people. And then when you actually become symptomatic, the first 7 days tend to be very mild, and most people, 90% or so, will actually recover from it without any serious complications. And most of the serious illness happens from the second week onwards, which is 7th day. The first observation change is Delta doesn't take 7 days. We think it's more somewhere between 5 and 6 days that it begins to get sicker. So obviously this virus appears to be a little more virulent. And now we getting data from South Africa that Omicron may be having even a shorter incubation period. So what we need to watch is if people get really sick from Omicron, will it be in the second week or earlier? So that's something that we are watching. And I'm going to move next to just to give an update on monoclonal antibodies to set the discussion for Omicron and what the impact will be on us. So that's the reason why I selected certain topics. So the change for 2021 to 2022 is the monoclonal antibodies will now be used in 3 different ways. One is pre-exposure prophylaxis, a new one called Evusheld has just been approved in the United States, soon to be available in India and elsewhere too. So this is a medication that is an injectable medication. It's intramuscular. It protects you from developing COVID, getting infected actually. So it works like a vaccine for 6 months duration. So who would you give it to? You give it to people who received vaccination and failed to develop immunity because of underlying immunological disorders like cancer or HIV or on immunosuppressive agents. So this would be the drug that you would be giving. Each shot will give you 6 months of protection. It's an intramuscular shot and it's given twice a year. So that's just been approved. So this is something new that to look forward to. So in patients who have vaccine failures. We already know that post-exposure prophylaxis, Regeneron monoclonal antibodies is now being used, and it reduces post-exposure prophylaxis better than 95% or so. We use it in the United States, and it's available as such in India too. Now, for the treatment of COVID-positive patients, we still use it in early stages in patients who have significant risk factors. They've been used widely in the United States, and they reduce hospitalizations by 80–90%, and actually deaths about the same. So it's a highly effective medication. What's the update now is that we are now beginning to use it in pregnant patients, and we have data showing that it's not harmful to the fetus or the mother. So I think monoclonal antibodies can be used with relatively with more confidence in pregnant patients. We believe pregnant patients with COVID are at a higher risk, and therefore they should be used. And the other 3 antibodies by Regeneron, Eli Lilly, and Sotorumab are also used, and I'll comment about that in a minute. So the new thing that we have to worry about, what about antibodies in general, whether it be from monoclonal antibodies or whether they come from infection or they come from immunity. This is a schema, a high-resolution crystallography of a spike protein. And all these different colors that you're seeing are epitopes where antibodies come and attach themselves. So these different colors are different antibodies. And I want you to point to this portion, the bottom right, where you're seeing this crystallography showing 3 different colors of the antigen, the epitopes on the receptor binding domain. So the dark blue is the highly conserved portion. The light blue is the highly variable portion. So this is where you're now beginning to see the Omicrons and the Deltas and the vaccine failures. So the more conserved the protein is, the less likely that it will have mutations. So if you produce vaccines against them or monoclonal antibodies against the most conserved portion of the protein, they're likely to last for a long time, be effective. On the other hand, if you produce vaccines or antibodies against the lighter blue section of it, then they're likely to break through it. And we believe that the new version the newest variant, Omicron. Just for a comparison, this is Delta on your left, and the particular mutation that we worry about for immune evasion is E484. It's called the EC mutation. And if you can see, these are the three that we see in Delta. And if you go to Omicron, it has enormous amount of these mutations that we are seeing, so significantly greater number of mutations. And these mutations translate to effectiveness of the monoclonal antibodies. So that these are different monoclonal antibodies, these are different variants of the virus. And if they're green, that means it's effective. If it's red, it means it's not effective. As you can see, the Eli Lilly product is already showing a fair amount of failure. Currently, the Regeneron product seems to be fairly effective against most of the variants except for Omicron. And Sotrovimab, on the other hand, appears to be the best of the available vaccines. So when you go back to this attack here, where the dark blue section are, then they'll remain effective. And if you are anywhere else, they're not going to, there will be immune escape. And we believe that now when you look at Omicron, the newest variant, these are all the variations, the amino acid substitutions that it has acquired over a period of time. I think the reason why it has developed, we believe, one is there's so much of immunity now across the world. So the virus has to find ways to evade our immunity. Number two, in South Africa, where 13% of the population is HIV positive, they don't clear virus fast enough. So normally, a healthy person will clear the virus in their body by 10 to 14 days. In HIV, it may take 20 to 30 days. And there are HIV patients who take nearly 200 days to clear the virus. So when that happens, when you allow the virus to fester in your body for nearly 200 days, you're giving it plenty of opportunity to develop mutations. And in Omicron, these are all the mutations that it has acquired, which is enormous in terms of comparison to Delta. So the first few things that I want to point out is the ones that I underlined are the mutations that allow the virus to, number one, attach to the the spike protein, the ACE receptor much better. Number two, it also allows it to transmit much better. But at the same time, it has the mutation, the famous D614 gene. Of all the mutations that we know of, this particular mutation actually increases virulence. So the big difference between Delta, Beta, and the Wuhan is the acquiring of the D614 gene. So this particular mutation made the virus more virulent in Delta and Beta, and we think Omicron having the same gives it that advantage that it can't be a mild illness, that it could also cause modest to severe illness. Likewise, the Del670 mutation allows it to escape, to make the monoclonal antibodies less effective. So knowing these mutations now, we have better insights into the variant that's about to come. So a little bit more about Omicron, because I think this is the virus that we're watching, although Delta is still the dominant infection in the United States. So for a variant to be important, it needs to be more transmissible. It is a variant of concern. You have to meet three criteria. Number one, is it more transmissible? We think it is. In UK data, it's showing it's at least threefold more transmissible than Delta. Number two, in South Africa, the R value is 2.5. Currently, Delta has an R value of 1 to 1.2. So clearly, it's more transmissible. The secondary attack rate for Omicron, at least in South African data and UK data, shows it has at least 20%, which is twice as much as Delta. Immune escape is the second category that you are looking for. And clearly it has that capability in South Africa, in the United States and UK. It has already infected people who had previously proven infections with alpha, beta, and delta. So this is another thing that to watch out for. So just because you were previously infected with one virus, it doesn't mean that you have immunity against Omicron. Likewise, when you look at vaccinated individuals, and they looked at patients who got an mRNA vaccines in the United States and AstraZeneca vaccines in UK, it escaped through it. There were actually a majority of patients who were infected in the United States, being travelers, were people who were fully vaccinated and the virus broke through it and infected them. The good news is they were all mild, but nevertheless, it is very worrisome to see that it break through vaccination status. Did it also, as you saw right now, the strategy in the United States is to offer booster doses to everyone. So when you look at booster doses and Delta infections, we have seen very, very few Delta virus infections in patients who completed fully 2 doses and received the 3rd dose of vaccine. We've rarely seen breakthrough infections in them. On the other hand, Omicron has broken through it in the United States as well as in UK. And finally, is it more virulent than Delta, or for that matter, Beta? Number one, there are no deaths reported in USA or UK or in South Africa where the infection is growing. But there are 2 things that are worrisome that we're watching. In the UK, in November, we use cyclic thresholds as an indirect measure to see if the viral loads are high or low. So in November, when UK was measuring viral thresholds for the initial Omicron infections, the viral thresholds were fairly high. They were around 30. By the time December came, the viral thresholds have now dropped to 23 or so, showing that the amount of viral load has gone up. So the virus, as it's taking a foothold in that community, it is beginning to become more serious than what we are seeing in the reports. Always remember, when an outbreak surge starts, initially most infections tend to be mild. It is after 6 weeks or so then you can see the true virulence of the virus. And likewise, in the South African infections right now, in South Africa, what happened is in December of first week of December, the infections have gone up by 400% in South Africa, number one. And 3% of the infections are now getting admitted, which is much more lower than Delta. Delta had 20% admissions. On the other hand, Omicron had only 3% admissions, which is good. But 3% are still getting admitted, and 86% of those who were admitted were unvaccinated patients. So what it tells us, if you're not vaccinated, that Omicron may not be such a mild infection, but at least will cause enough infections to get admitted to a hospital. Thankfully, there were no excess deaths so far, but we're very early in this pandemic. What about vaccine efficacy and Omicron? Right now, vaccines, 2 doses of vaccine clearly are preventing death. So that's good news there. The vaccines are preventing deaths in patients who receive 2 doses of the vaccine. That's the good. And it seems to maintain that potency even beyond 10 months. And we believe it's because of the memory T cells. So studies that were done on T cells clearly showed that there are very few mutations in Omicron that can block T cell function. It has many mutations that block antibodies, but not so many mutations to block T cells. So in a way, if we get 2 doses of vaccines, I think deaths can be prevented with Omicron. That data is now emerging. Booster doses appear to decrease infections in the UK data by at least 75%. So the 75% efficacy with 3rd dose of vaccine in the UK data. Likewise, similar data exists for in Israel too. But it's also important to remember that as we speak, they were doing clinical trials for developing vaccines that target beta and delta variants. And so now the vaccine manufacturers decided that perhaps booster doses will be adequate to manage beta and delta, but may not be adequate to treat Omicron. So Pfizer just announced that they will change their vaccine to meet the requirements for Omicron, and they will take about 100 days to deliver the new type of vaccine that negates Omicron. And I think what is the future, since we are talking about the next wave, more recent research showed there's a new part of the virus that hitherto we didn't know about, which is very conserved. So when the spike protein actually opens like a clover deep inside, and it exposes itself only when the spike protein opens up, is a site called the site 5. It's a kind of cryptic site, the SH2H97. We believe this is the site for future monoclonal antibodies and vaccines. And developing vaccines against this site, which is highly conserved, probably will help us to have vaccines which future-proof. So once you develop vaccines which will negate the effects of mutations, then that is probably the direction we need to go to end this pandemic eventually, to have a vaccine that permanently protects us instead of every 4 months taking shots and every 6 months taking boosters. That probably is not practical, and having a vaccine that prevents future mutations is the way to go. So up till now, we developed vaccines and monoclonal antibodies which have high potency, but they don't have a large breadth. So when a virus mutates, we're not able to cover it. So the future would be that you want a vaccine that has a lot of breadth as well as depth, so that it will negate any mutations that are coming. So finally, for the sake of time, I'm going to skip all the therapeutics because we covered a lot. But I do want to point out one particular therapeutic, which is dexamethasone, which is widely used. Again, I want to make this point that I use this graph that steroids should not be used in the first week of illness. They should really be used in the second week. I think this is one of the reasons we are worried that in India mucormycosis is developing so much, is that steroids were widely used and not used appropriately. So I want to make that point again, that you want to use steroids in the second week of the illness and not in the first week. Number two, you should only use steroids if the patient is hypoxic and has significant disease and not otherwise. So what we have seen in the current wave is that dexamethasone of 6 milligrams is not showing the same benefit it showed the last time. So that's why I brought this back up. So there's a new randomized trial where they compared 12 milligrams of dexamethasone and 6 milligrams of against 6 milligrams of Dexa, and showed that 12 milligrams is better to 6 milligrams, except it never reached statistical significance. But the point here is that they didn't power the study adequately, so therefore we didn't see the p-value that we're looking for. But for every measure that you look for, it has shown that it is better to use 12 milligrams. But I warn you that we need to be this is preliminary. We have to watch this. We are seeing, number one, that 6 milligrams is not working that well. 12 milligrams may be the better way to use it, but with the two important caveats that we should not use it beyond 10 days, number one. Number two, use it only in the second week of illness. I think that would be something that will be changed going forward. And in terms of anticoagulants, I think two important points I want to make. Number one is if a patient is low D-dimer levels, if the patient's D-dimers are normal, we have not seen them have clots. So that's one of the screening tests that we want to use. There's a good study coming out of Florida where they did imaging studies and D-dimers and found that if the D-dimers were normal, there is no value of, they're unlikely to have thrombosis. The second thing also, the take-home point here is that if a patient has a clot, anticoagulants really work. So we need to make effort to find the clot as much as we can and treat accordingly, and not just give everybody a full anticoagulation. And finally, 3 new things that are coming. When the pandemic first came, what we saw was that patients who had psychiatric illnesses did better than patients who didn't have psychiatric illnesses in our inpatient setting. That set the ball rolling to understand, why are these patients more protected than people who didn't have psychiatric illnesses. And we found that they were taking various antipsychotic medications like SSRIs, and they found that for some reason, presence using those medications protected patients from having progression of illness and even death. So that prompted us to search for these as a medication to be used against COVID. And so the first 2 major trials have come up. The fluvoxamine, a regular antidepressant, fairly cheap. It's $5 for the whole course in the United States, given 10 milligrams twice a day. And the study clearly shows an absolute risk reduction by 4.5% and the relative risk reduction of 31%. The drug gives you some side effects in terms of diarrhea, but it's one of the better drugs that's showing some data instead of what we had been trying, things like ivermectin and things, other hydrochloroquine. Here's a drug that's finally beginning to show some benefit. So this is one of the new developments that we have. And of course, the biggest advance we think that will come in the next several weeks. We expect this drug to be approved in the United States in about 4 to 6 weeks, and will become available around the same time in India, which is Pfizer's Paxlovid. The drug was given in 1,200 patients. The medication was started within 3 days, and if they got the medication, only 3 ended up being hospitalized. And if they got placebo, 27. And then when you look at the total number of those who received within 5 days and 3 days, there were absolutely no deaths in those who got Paxlovid and 10 deaths in those who received a placebo. This is nearly a 80–90% reduction in death. It's an oral pill, and this would be really beneficial to have in a panacea as we go forward. Number one, it's an oral pill. Number two, it is not going to be affected by the variants that have emerged. So be it Delta, be it Omicron, it targets a different portion of the virus. So it's unlikely to be affected by Omicron and still will be available for us to be used in anyone. So going forward, before I end, and then we'll have plenty of time for discussions, I hope, this is how I see the future, how we will be treating. Earlier, the secretary had said that the Andhra Pradesh had very good capability of testing patients. I think they become very important in the next wave. So any patient who develops any kind of COVID-like symptoms would get tested, and these drugs are not yet available in India, but I can see them becoming available in the next few months. So they would be tested. If the test is positive, then you would immediately, so as soon as possible, so within 3 days of symptoms, we'll either give Paxlovid or the new Merck drug, which is not as effective as this. So I didn't put it up there. It showed only a 30% reduction in mortality, which is still better than nothing. But Paxlovid, a 90% reduction is probably what we should be aiming for. So I think in the future, that's what we would do. We would test a person, give them Paxlovid as soon as we can. And that the effect would show itself within 5 days because it's a 5-day course. And hopefully, if the patient doesn't get better at that point, we still have a 3-day window to give monoclonal antibodies and suppress the progression of disease. And on the other hand, if people can't afford these antivirals, I think fluvoxamine is seen to be reasonable. It's a 10-day course. So rather than give erythromycin and ivermectin and all those medications which have shown no benefit, maybe the future would be fluvoxamine, 100 milligrams twice a day, and Tylenol or something else for patients so that to prevent progression of disease. The problem with both these drugs, Paxlovid and fluvoxamine, is they don't work once you are in a severe phase of the illness. So in the second week, they are useless. So they have to be used early, and that's where the biggest bang for the buck. It is similar with monoclonal antibodies. They're only helpful early. Once you go into the second phase, with the 7 days where you would get developing ARDS and severe pneumonias, they are unlikely to work. So in summary, what I wanted to do, I kind of raced through a lot, is one is that what you need to watch out for in India is that the clinical presentation has changed. And so whatever dogma that you had, start thinking differently, that if you're looking for markers, that has changed. The markers are not as prominent as they used to. If you're depending them on exclusively to decide on how you want to treat patients, that is going to be a problem. Second, immune escape variants. I think the Omicron so far has called mild infections, but you have to be concerned about it because it has this enormous capability to escape the immunity from previous infection and vaccines. And it's in the very early stages in India and in the United States. US is rapidly pushing booster doses, so is UK. I think India's goal would be to vaccinate as many people as possible because you want to prevent deaths from Omicron at all costs. And hopefully, if we can get everybody to get 2 doses, switch over to giving booster doses to people who are at risk at least. Right now, India has the vaccines, so I hope the government will push vaccines even faster. 48% 2-dose. It seems to be a good number, but I don't think it'll be adequate for Omicron. So Omicron, either 2 doses or it doesn't work. So we need to push 2 doses as much as we can. And just a word of science that developed over the last several months is this COVID's ability to infect adipose tissue and replicate there. And is that the reason why when your BMI is higher, you're more likely to die? We don't know, but I think this is a great area of research that has emerged, and we will hear more and more about that. And finally, I want to point out that whatever it is, there is excess mortality, and we need to prepare the lay public because, again, I don't want them to suddenly be surprised. Why did the patient die of this? There is excess death rate from all causes, and the more we spread that information, the less likely they will be frustrated with outcomes that we have. There's a 30% excess death rate from all causes, and it probably is directly or indirectly related to the pandemic. With that, I'll stop and take questions now. Karam, you want to go through?
Yes, I will go through the chat box in a minute, but I have one question for myself, Sridhar.
Yeah.
This observation regarding SSRIs reducing mortality was a bit of a surprise when I first heard it. Is it prophylactic people, psychiatric patients who happen to be on SSRI had less disease, less mortality, or was it given as a treatment?
No, so the first thing, they were already on those drugs. So they were already on because they're psych wards, right? So if you look at just for comparison, in the psych wards, we had in the medical wards, when we had nearly 350 infections, the psych wards had 9 infections. And they were all in the South Bronx, where the test rates at that point was 50% were positive. In April of 2020, 50% of all tests in the Bronx were positive, the hottest COVID spot at that point. Nevertheless, only 9 patients were tested positive, and they were all on antipsychotics. So this was observed all across the United States and UK. So that's the reason why they went to search for a drug that may have an effect indirectly. They think it works through the nitrous oxide synthetase and blocks the virus replication that way. And so that's why antipsychotics have gained momentum, antidepressants more than psychotics to be effective, and that's how fluoxamine was tested.
Thank you. Doctor, there are several questions on the chat box. I will go from the beginning. One second.
I can, too many for me to read, so you have to read.
No, I will do that in a second.
Yeah, and anyone can also speak up if they wish to.
One second. There were a couple of questions related to the availability of the imdevimab. I had understood that the combination was available through Roche and Cipla. Do you know, or does anybody else know, what is the availability of the combination antibody right now?
In India?
In India.
Yeah, I don't know the availability in India.
Dr. Sudhakar?
Yeah, it is.
It is available.
It is very much available.
Available.
Casirivimab, imdevimab.
Yeah, actually, Cipla is marketing this, and we have administered for more than 150 patients this monoclonal and casirivimab imdevimab.
Okay.
Actually, 600 mg plus 600 mg.
Yeah.
It's available, very much available.
Now, the other question that keeps up, Dr. Chilimuri, in order for the people think that a new mRNA vaccine has to be constructed to be effective against Omicron. If it is, it has to go through the approval process again. It's not simply a matter of giving another dose. Is that not correct?
So, so the approval process they started. So here's the thing: the next phase of vaccine trials are done totally differently. So we no longer can do placebo-controlled trials. So the original trials, post AstraZeneca, Covaxin in India, were done as placebo-controlled trials. That's no longer possible because you won't find patients who are unvaccinated, or it may be unethical now to not vaccinate people, knowing that it's a very effective vaccine. So the way they're going to do the trials is to just do blood assays. So you would give vaccine, then check if there are any side effects from it. Number two, then check for neutralizing antibodies. So that's how the Delta and the Beta vaccine trials are going on in the US. So right now they enroll 950 patients with this new type of vaccine, which is targeted to Delta, by the way. So the FDA in the United States is saying, okay, we'll accept that maybe going forward, just blood assays showing that the better neutralizing antibodies have formed. So there won't be a placebo-controlled trial. So they already set up the platform for it. So they need to switch from Delta vaccine to Omicron vaccine. That's the idea, to just stop whatever that's in development and switch over to Omicron.
And one of our participants, Dr. Polisetti, wrote in the chat box that I think we heard the CEO of Pfizer talking about a new mRNA vaccine for Delta, restructured, made, but they did not put it into use because the earlier vaccines were already noted to be effective.
Yes.
That may be true, but if you take that forward to Omicron, is it fair to say that there is no new vaccine that will be available against Omicron? So our only hope is to get everybody vaccinated with the current vaccine, correct?
Absolutely. The Omicron variant won't be developed for at least another 100 days. So, but on the other hand, he's saying that moment it's ready, once 100 days from now, they will be able to produce large quantities of the vaccine. But we're still 4 months away. I think that you made it a very important point. Omicron does not cause serious infections once you get 2 doses of the current vaccine, serious infections. It will still break through and cause minor infections, but the goal is to prevent deaths. I think for that purpose, we need to push as much vaccines as we can. Even before booster, I would rather push 2 doses. 43 or 45% in India is not adequate at all for Omicron. 61% in the United States is not adequate. Even better number in UK, already shown to be inadequate. In UK, the number is doubling by every 2 days, number one. They expect by the end of this month that Omicron will be the dominant virus in UK.
That takes me to the next fear. You had mentioned many times in the past, the impact of mucormycosis was predominantly in India. And as of now, the best culprit we can identify was early introduction of steroids, too high a dose of steroids, and for too long. So today, when you were presenting data on the 12 milligram dexamethasone, it scared me.
Yeah, that's why.
Go ahead.
Yeah. No, so that's why I warned us. I repeatedly showed the graphic that you should not use steroids early. And you want to only use it in the second week onwards, and only those who are severely ill. You don't want to give it in mild infections, number one, and you don't want to give it in people who are not hypoxic either. In fact, in the original trial, when they gave steroids to people who did not have hypoxia, it actually made them worse, actually, not better. So I think hypoxia is the main important point why you want to give dexamethasone. And you want to stop at 10 days. The trial stopped at 10 days. That's our standard of therapy in the US. We don't give beyond 10 days. In India, steroids may not have been the only reason why mucormycosis. There may be other factors that are still not very clear why that has happened, but thankfully the numbers have gone down.
Okay. Another important question is, I had been waiting for the data on Paxlovid. You gave a summary today, but Dr. Somini is asking, are there any recommendations for prenatal patients and children? They were not included in the trials, correct? So there's no recommendation as yet.
Yeah, so Paxlovid did not include pregnant patients. No, didn't include children either, by the way. It's only for adults with risk factors currently.
Dr. Polisetti has another question. Waiting for 2-week window for starting steroids is tricky because right now we see mostly anti-vaxxers who do not watch their symptoms, nor they give accurate time of onset. Is there any new inflammatory marker that seem to indicate severity?
No, I mean, there are many that every day new markers are being tested. Firstly, they're not so practical, number one, to do them. So even if you develop a marker on day one, you have to do bloods on everybody. So why would you want to do that? 90% of people who get COVID have a very mild illness. So why would you want to do blood tests on everyone that you can? So I think that's why I said right up front, good history, which involves, are you vaccinated, not vaccinated? When did you get your vaccine is the starting point. And then after that, you can correlate symptoms to it. So we're using telehealth quite a bit. So I think you want to get that information as well as you can. If you tell patients this is life and death decision, I have to decide to give you steroids, and this is the point where I want to start. So I want to know exactly how many days you have. Because if I give it too late, it's worse. It'll actually not help you. It'll make it worse. If you give it too early, also, it'll do the same thing. So you really want perfect timing. I think patients, when you explain to them the importance of this, they'll come through. I think we need to pay some attention. There's some hand-holding is necessary. You know, we can't, we have to show that caring and that value of giving that personalized attention to individual patients. Yeah, Dr. Prem Kumar, go ahead.
Yeah, I was going to ask Dr. Prem Kumar if he has a quick update on the revised guidelines, and also to address Dr. Polisetti's question, is baricitinib being used along with remdesivir for severe COVID? I have my own answer, but I will shut up. Dr. Prem Kumar.
At the outset, I must congratulate Dr. Sridhar, and I'm also thankful for the vision and guidance you have imparted on us, how to go about in the future in the wake of Omicron. And in your lecture, you have mentioned that the inflammatory markers are very low, like D-dimer and CRP and all. And keeping in view of this low inflammatory state or inflammatory markers are low, how would we justify escalating the dose of dexamethasone from patients and 32 in the spike or 10 to 15 in the RBD? So, are we failing in the genomic surveillance, or the three possibilities like the mutations are going on in an unmonitored pocket, or whether the mutation is going on in a immunocompromised host who has been hosting the virus for quite a long time, or the virus has gone back to a wild reservoir or a domestic reservoir where we have failed to monitor, and again after so many mutations came back. So these are the couple of quick questions from my side, Dr. Sridhar.
So let me answer the steroid question. But I think you made a very valid point. The data I showed, the study that involved did have high markers. So this was done during the previous year data. So that's not current. What I'm sharing in terms of the markers have disappeared is now. So this is our current experience, which I would hope that you would be, I think in 2-3 months, you would be seeing that in India, in your ICUs, that the LDH is not that high and the markers are not high. And this is, I'm sharing it with everyone. We haven't published this data yet. So if the markers are not that high, what is the justification to give a higher dose of steroids? Probably not. And probably this is something that we may not end up doing if this trend continues. We have seen that steroids, remember 30% reduction, I'm not seeing that anymore. So we're not seeing the benefit of steroids as we saw in the first two waves of it. So I think this is something we need to go back and look at it. So maybe steroids is not the answer in the next phase. Antiviral agents like Paxlovid may be the future, and maybe easily administered monoclonal antibodies may be the future. And I think we can't depend on steroids in the next phase of the pandemic. I think it's done its job, but I'm not so sure that's the future. That's number one. Number two, why did the virus emerge? I think we only this year, we have now gained some capabilities in genotyping. It's very weak in many parts of the world. Finally, US has caught up with it. Interestingly, South Africa is actually very strong in doing genotyping. And I think we still should congratulate them for identifying it, even when they identified it. It looks like it took a long time to identify. I think you hit on two important things, and you're probably right, that we are not checking all the pockets of infections that are all over the country. South Africa, the cities are dense, and beyond that, it's very sparse population. All of Africa is like that. And who knows what's emerging there. And there's no outreach into that communities. And so therefore, we don't know what is happening in people who are, let's say they got steroids for too long, and what's the virus doing in them. There was at one time a belief that convalescent plasma may actually be pushing people to develop emergent variants. There's one great case report on Hopkins where they were giving large doses of steroids to a patient who had anticardiolipin syndrome and got infected with COVID. And while they were watching, the virus was mutating on a regular basis, and they were petrified how amazing it was mutating in the presence of steroids. So, and the last one, is there an animal reservoir that it's going back into animals and coming back mutated? That's very much, we were worried about it when mink in Europe got infected and passed it back to human beings. So these are all the areas that we need to, as you pointed out rightly, that we need to go search and see where it is hiding and where it's emerging. I think India doing more genotyping is a good start. I think Andhra Pradesh is starting, the health secretary pointed out. But we are not anywhere where we want to be in terms of capacity to do genotyping. We need to do a lot more. US is doing about 80,000 or so. The US is currently doing 15% of all isolations right now. All positive tests, 15% they're doing, which is pretty good number if they can sustain it. But we're revving up even more, and hopefully we'll identify future variants much earlier than where we are right now.
Another quick question, Dr. Chilamuri. Dr. Padmalasta asked a question that intrigued me. With startling data regarding psychiatric ward patients on SSRIs having less infection, of those that got infected, was there lower mortality?
Yes, there was. There were lower mortality in them. So it prevented infection, and it also decreased mortality. So there are definitely lower mortality in them. It's well known, actually.
Okay. There is still Dr. Vijay Sekhar is asking, there is still a lot of vaccine hesitancy among pregnant patients in India. What were the strategies involved in America to reduce this hesitancy among the pregnant women?
So number one, America is not the model that you want to follow in terms of vaccine hesitancy. We are a total disgrace, actually. We are the worst. There's enormous amount of vaccine available in the United States. It's free. Anyone can walk in and get a vaccine, but the vaccine rates are relatively unsatisfactory. They're around 60% right now. Pregnant women, first, I think they needed safety data. So how did women take it? So we had to show more safety data, and that became available. Number one, you saw two major studies showing that abortions are not more common if you get vaccinated versus unvaccinated. So that was very important data people wanted to see, and so that data is available. And then we had many live births that happened after vaccination, and the baby was healthy. Yes, they had antibodies, but they were quite healthy. And the third data that you want to show is that when patients got COVID infected during pregnancy, there was a higher rate of stillbirth and termination of pregnancy. So you want to share that data also with pregnant women. So hopefully they'll be more convinced about it. There is hesitancy though, but I think we have more and more data showing that it's safe to give it in pregnancy.
Okay. There's a specific question. You may have addressed it in your general comments. Here is one of our alumni, 74 years old, practicing anesthesiologist, goes in front of people's faces too close too often. He received the third dose of Covishield in November. How much protection can he expect against the Omicron variant?
The first, I think he should continue. My first change I would do is cloth mask should go. I think more and more physicians should not use cloth masks at all. I think we should use surgical masks, and I think somebody like anesthesia absolutely has to wear an N95 when approaching patients, number one. With third dose of Covishield, so the data shows that if you mix vaccines with an mRNA. So do 2 Covishield, 1 mRNA, you get the best bang for it. But it's not to say that 3 doses of Covishield is inferior. They're pretty good too. I think what he's going to benefit the most is for the next 4 months. So when you get a booster, you definitely get good protection for 4 more months from it. Why not 6 months? Well, the data is 4 months right now, and it certainly works 4 months after you get the third booster dose very effectively. Looks like even stops Omicron by at least 75% after the booster dose. So he did the right thing by getting the booster dose. I would also, if there's always a chance to get mRNA, I hope India will get them, and I would switch the third dose to an mRNA dose if possible.
I was not aware of information regarding an alternate reservoir. Dr. Matan Sastry is pointing to a report about deer becoming a significant reservoir species. Have you heard this, or is there?
No, that's why I think he makes a good point. I think deer, mink is well known. Deer is known. Other animals in the zoo all have been infected. So zoonosis is a problem. We haven't studied it enough. but it staying as a reservoir is a potential problem.
There is still a persistent question regarding the amount of the dose of the booster. Is it the same as the first and the second, or is it a different dose?
For Pfizer, it's the same dose. For Moderna mRNA, they reduced the dose. For the remaining vaccines, it's the same dose.
Is there a firm recommendation as of right now regarding the second booster, that is dose number 4?
No recommendation to get a fourth dose yet. No recommendation at all. We are at 3 doses now officially.
Doses, yeah. So I will have a question for Dr. Sudhakar and Dr. Prem Kumar. We keep hearing about X% of eligible population being vaccinated. Can you define eligibility?
Yeah. Ramohan, eligibility in India is those who are over 18 years. So amongst the population of 140 crores that we have here, those who are above 18 years are all eligible population.
That's right. Okay, that's very high. I needed that clarification. Dr.
I just want to add one more clarification. So boosters should not be confused with third doses. So if you have an immune compromised state, then it's 3 doses in a row. Okay, so that's not booster. Booster is otherwise healthy people who get 2 doses, then wait 6 months for their booster dose. Okay, so but on the other hand, if you have cancer, it's 3 doses in a row at exactly the same intervals.
Dr. Pilla has a comment. Maybe she could answer Dr. Vijay Shekhar's question. Dr. Pilla, proceed.
Dr. Chilamuri, thank you very much. Again, it's a stellar lecture. One question I have is how often the healthcare workers or the high-risk population should get their antibodies tested? Is it necessary? Or if it is so, then how often? My second question is, I got Pfizer vaccine 1, 2, as well as booster. Now that you mentioned that they're adding Omicron to the newest vaccine that they're producing. So should I take it, or should I get my antibodies tested before I take the second booster? Thank you.
Okay. Yeah. So number one, antibody titers monitoring is not recommended. Number one is because the titers only are not reliable. Number one, the titers are not always measuring neutralizing antibodies. So time duration is more reliable. So 6 months after the second dose is when we tell people to get their booster doses. The only group that I would do titers is those who are immunosuppressed, if they have cancer, and if you don't know if they responded or not, like somebody who are transplants, in them we want to know if they have adequate antibodies, because we could consider monoclonal antibodies as prophylaxis in that. The rest of the population, using antibodies to determine whether they should get boosters or not is flawed, because we've seen in about 50 patients breakthrough infections that we are studying, nearly 25% had fairly high titers of antibodies when it break through. This is Delta, actually, not even Omicron. So I think using those titers as deciding when to take vaccine is flawed, and I wouldn't recommend it at all. Now, the Omicron vaccine is not ready yet. I think when it becomes available, it's very likely they will ask us to take another dose of the vaccine when it comes.
Dr. Prem Kumar has raised his hand.
Yeah, the casirivimab, imdevimab monoclonal antibody is not working against Omicron, and glad that GSK's sotrovimab is working.
Yeah.
So until the sotrovimab is available in India, I have an idea. Can we fall back again to the convalescent plasma from those people who recovered from this Omicron variant until we get this sotrovimab?
Yeah, so I still would use Regeneron against Omicron. I didn't say it's not working, it's a reduced activity. So even if it works 50%, I will take it. So I would still give it. I wouldn't say don't give it. just be careful that it may not work. So just warn the patient, we'll give it. If it helps, it helps. And there's a good chance it'll help, then fail. Now, convalescent plasma. So this is the debate when the WHO decided to cancel convalescent plasma as a recommendation. There was enormous fight in their scientists saying this may not be a smart idea with a new virus that has emerged. I think what we found about convalescent plasma, I think we now have better information why it works in some people and why it doesn't work in other people. So all plasma is not the same. That's what it infers. So if you give the virus to 10 people, each seem to produce a different spectrum of antibodies. So they don't produce the same polyclonal type of antibodies. Some will produce 12 different, some only 5, and some maybe 14 different antibodies. So we're clubbing all of them and saying this is one big plasma when it's not. So we threw oranges and apples into a basket and they say they're all the same. They're not, they're totally different. So I think if Omicron emerges to where it is, there's a good chance that we may go back to plasma. We may revisit the role of plasma again until we have another vaccine. So, so that's why I'm never hard against anything. I'm always open to new ideas because I think when you become dogmatic about it, that's when we harm patients. We need to be open-minded, listen to various ideas and explore them as much as you can. So I wouldn't say plasma is dead yet.
And Dr. Chilimuri, till now we don't have an immunological correlate at what precise level of antibody titers it is protective. So do you think that the vaccination coverage, say 70% or 60% or 48%, whatever people are talking, it truly translates into protection?
No, it doesn't. It doesn't. I think we are confusing efficacy to effectiveness. Efficacy is what you measure in a very controlled clinical trial where everything is controlled. You check the temperature of the vaccine, you do the bloods before, after, and 10 times after. And you monitor the patient every day. You make sure the dose was given correctly intramuscularly and not subcutaneously. All that is done in a clinical trial, and that's an efficacy trial. When they say 95%, that's an efficacy trial. Effectiveness trial is what really happens in clinical practice. Sometimes the vaccine is not stored properly. Sometimes a person may have a big hand and you're giving it all subcutaneously. Sometimes they may have an underlying immune defect and you don't know about it and you're giving them a vaccine. They should have gotten 3 doses. You only gave 2. So it will never be the same. I think it'll always be less effective than what they say in clinical trials.
Thank you very much. I'm done.
Before I turn the microphone back to Dr. Sudhakar.
Did you go through all the chat window questions? Did I answer all of them?
I was going to ask his permission. We have gone way beyond 90 minutes.
Okay.
Dr. Sudhakar, I believe I've gone through most of those, if not
Okay.
all.
You have 10 more minutes to go, Ram Mohan.
Okay. So what I wanted to say, as I thought I was closing it, is to be able to say, after all, this group is predominantly Andhra Medical College, hosted by Andhra Medical College, attended by current and former students of Andhra Medical College. I want to thank Dr. Chilimuri for what he has done to this forum for the past year and change. And that I hope he remains very strong, healthy, articulate, beat the heck out of this virus for himself, and continue to provide the kind of knowledge and current, verifiable, valid, evidence-proven medicine that he has been doing for the past 1 year. So as Dr. Sudhakar gave me this responsibility, I want to say I'm eternally thankful to what Dr. Chilimuri has done for all these months, not only from himself, and for providing me contact with so many of his other faculty members who have done a very great job on this platform. So Sridhar, from my end, thank you very much.
Yeah,
Thank you.
Ram Mohan.
I think I was you know, when you go to medical school, the medical school gives you a lot. It gives you everything, the skills. Andhra Medical College gave me the skills, the knowledge, the modesty, the humility, and the commitment to learn for the rest of my life. That's what Andhra Medical College taught me. And I know there are lots of students in the audience there. I hope that's the main message, that the college gives you a lot, and hopefully you will get a chance to give back to the college. And this is a humble effort to give back to a community and a college that made me who I am. So it's just a humble effort to give back to what Andhra Pradesh and Andhra Medical College has done for me. And it's a great privilege to be sharing this with you.
Yeah.
Thank you.
Yeah, Ram Mohan, before we wind up, I think we'll take a quick comment from both Dr. MSS Mukherjee and Dr. Muhammad Adrish. Both of them are online. Can they speak for a minute as to their reminiscences or their thoughts about this particular program?
Dr. Adrish? He was there earlier, but I don't see him anymore.
Yeah. Okay. Dr. Mukherjee, are you there? So he's also not there. It's okay. It's okay. No problem. No problem. Yeah. You can wind up. After you say bye-bye, then I have a few comments to make.
No, I am done. I just wanted to make sure. I wish Dr. Chilimuri all the success in the manner in which he communicates to his residents, other faculty, the audiences around the world. And I'm particularly pleased with the way he has been able to communicate through Enadu, Times of India, through this forum to India, because what India needed last summer was evidence-based medicine. From that standpoint, he has discharged his instruction extraordinarily well. So I want to use that last sentence to say to the students, please ask your professor, where did this recommendation come from? It's okay. People don't like when I talk like this, but it is okay for you to ask your professor, sir, what's the basis for this recommendation? Thank you. Dr. Adrish is back. So Dr. Adrish, Dr. Sudhakar was asking you to make a comment about your own thoughts as of now and your little experience with us over the last few sessions that you attended. Thank you.
I think it's been a great experience for me also. I thank you for this opportunity. You and Dr. Chilimuri introduced me to this forum, and I really, while preparing for these talks, I also learned myself a lot. So I think that helped me as well to provide better care to the patients in my own community. I'm very proud of this effort that has been put in by Dr. Sudhakar, and I think the next step that the organization has taken is to put these videos on the YouTube channel so that a lot more people can benefit from them. I think that is a very noble thing to do, to spread this knowledge, and that is going to go a long way. With regards to our experience at this time in Houston, where I am right now, the numbers have slowly started to pick up. As of this past Friday, we had about 5 patients in the ICU, and about 60 to 70% of our population in the ICU was unvaccinated, but we are beginning to see vaccinated patients also in the ICU. And these are the patients who have gotten 2 doses of vaccine, but not the booster shot. And they have not yet been intubated, but they are pretty sick on high flow oxygen. So yes, it is very, as Dr. Chilimuri also mentioned, it is pretty important to not only get vaccinated, but if you have been vaccinated for more than 6 months, to get a booster dose done, which I think is going to be our next challenge going forward for when we fight this infection.
Thank you very much, Dr. Adrish. I sincerely hope we don't have to be calling you back 2, 3, 5, 7 months from now because there is another spike of COVID in India. But you've been wonderful to me every time I call you with so readily accept on quick turnaround. So Dr. Chilimuri, thank you for providing Dr. Adrish. Dr. Adrish, thank you for helping to spread this information. Dr. Sudhakar, yours.
Yeah. Thank you very much, Ramohan, for so effectively conducting the entire proceedings of today, as well as your efforts in the last 1.5 years in introducing many speakers of quality. That's what I always say. They have given enormous knowledge, not only for people around this state, but also for people around the world. And people like Dr. Muhammad Adrish, Dr. Pratit Kulkarni, we can never forget the forceful presentations that they have made. And it's wonderful to see Dr. Mukherjee also chipping in many times in this particular program. And like you, I completely agree with each and every remark that you have made about Dr. Sridhar Chilimuri, my bosom friend. I'm very proud of him. And the last words that he has spoken today, expressing his gratitude to this institution and also guiding our students towards that end is something which is phenomenal. That truly reflects the character of Dr. Sridhar, and that's what we expect from all the alumni of this college. The Andhra Medical College is very proud of him, as well as you and all the AMCANA members over there, as well as those who are in India. And I thank you profusely for making this 100th episode a great event. And I thank Dr. Aviraju for being with us all through these 1.5 years. And I also thank him for bringing in the health secretary today to speak to us, who is a very important person because he's a very proactive and highly intelligent, and the person who looks after all the affairs of the health of the state. Thank you all very much. I thank Mr. Ravichandra Muddada IAS also on this occasion for giving a wonderful message today and telling us as to what the Andhra is heading for and how we are prepared. I thank all the participants, particularly the students who have gathered in large number in front of the Panagal buildings to witness this momentous occasion of 100th episode of the webinars that we've been conducting over the past almost 18 months. Thank you very much. With that note, I conclude this meeting. Bye-bye, and have a wonderful year ahead. The 2022 should not be like 2021 or 2020. I think in 2022, we'll all be better off. And wish you all the very best. God bless every one of us. Thank you all. Good night. And have a good day for those who are in America. Thank you. Bye-bye.
Thank you. And
Thank you all. Thank you, Sridhar. Thank you, Ram.
Okay.
Thank you, sir, principals.
Bye-bye.